There we go. All right. Well, welcome everyone. For those of you that I do not know, my name is Carol Sale, and I have the privilege of being the president and the CEO of the Williamsburg Health Foundation. We are delighted with the turnout for today's session, including our distinguished panel, health and board members, and many of our community leaders. So thank you for attending. Understanding that behavioral health is essential to overall health, the Williamsburg Health Foundation has supported child and adolescent behavioral health throughout the years with grants, networking, and convening since 1998. Our Child and Adolescent Behavioral Health Provider Network was launched in 2008, following a community dialogue with those providing services in the field. There have been a number of changes and advances in approaches over the years, and we're grateful to be part of a community where collaboration and implementation of evidence-based methods are very evident. The current Williamsburg Health Foundation strategic plan includes behavioral health services among our priorities, with an interest in working with children and families. Your presence with us today underscores the importance of and the interest in this topic. Before I turn the meeting over to our Senior Program Officer, Paulette Parker, I would like to just walk through a couple of things that we would like for you to do. I would like to ask everyone who is not participating as a panel member to please turn off your video and mute your audio. You may put any questions that you may have into the chat box, which you can find at the bottom of your screen. And I will periodically interrupt the discussion to ask your questions. When we get to the overall question and answer period, Paulette will invite you to turn your video back on, unmute yourself, and so you will have, if you have any additional questions, you'll be free to ask away. So thank you for that. Paulette, I'd like to turn the meeting over to you now to facilitate this important discussion.
Thank you so much, Carol. And let me just add my welcome to what Carol has already shared. We have an outstanding panel today and many distinguished guests, and we really appreciate you taking your time to be with us. We invite you to ask questions, as Carol said, in the chat, and we will get to them as quickly as possible. And then we also have a good time amount set aside for questions and discussion at the end. A couple of points about our topic for those of us who don't work in the field every day. Children's behavioral health refers to anyone under the age of 18, so both children and adolescents. Also, we're going to be using the phrases behavioral health and mental health synonymously. As we're listening to the panelists and during the questions and discussion, we'll be hearing about challenges being faced, as well as stories of innovation, resilience, and success. We'll also be hearing about the power of community and the importance of collaboration in supporting the behavioral health of our children, adolescents, and their families. Behavioral health challenges among children have been evident over recent decades. Pre-pandemic data indicate that 15 to 20% of children experience a mental health disorder in any given year. Yet only about 25 to 30% receive appropriate diagnosis and treatment. In Virginia, 14% of adolescents report having had a major depressive episode within the past year, and 1 in 3 high schoolers say they felt sad or hopeless almost every day for 2 weeks or more in a row. These prevalence rates are backed up by the experience and observations of the panelists we have with us. Support for children's behavioral health takes place at multiple levels, including families, friends, schools, and the organizations that are providing services. Each of our panelists has a slightly different vantage point, and together they comprise a well-rounded view of our community. A common phrase, as you know, over the past 15 months has been social isolation. This has come up in many contexts, but frequently around behavioral health impacts. At this point, the conversation is pivoting, and it's more common to hear words like reentry. Reentry can involve challenges of its own, particularly for those who are experiencing various degrees of social anxiety. Thinking about a longer timeline beyond the pandemic, what we'll hear today is that there are no panaceas, silver bullets, or one-size-fits-all solutions, but there are reasons for hope. Our panelists are among those who have a community perspective and are providing effective services to the children and adolescents fortunate enough to be receiving diagnosis and care. At this time, I'm going to call on the panelists one by one to briefly introduce themselves, and then I'll come back around for us to hear from each of them. So Lou Rossiter, could you lead off?
Hi, I'm Lou Rossiter. I'm the leftover last year board chair, and I'm an economist and also a health policy wonk, which wonk is no spelled backwards.
Yeah. Yes, and ready to add a little levity to this sometimes serious topic. Liz Urphy-Howard.
Hi, I'm Liz Urphy-Howard. I'm the Children's Services Clinical Coordinator at Colonial Behavioral Health.
Very good. And Rebecca Sheffield, we're so glad that you overcame some technical difficulties. Would you like to introduce yourself?
Absolutely. And of course, I would have technical difficulties just as I'm trying to log on. So I apologize for that. But my name is Rebecca Sheffield. I'm core faculty in the Counselor Education Department at William & Mary, and I'm the director of the Flanagan Counselor Education Clinic.
Thank you. And Lindsay Purse.
Hi, I'm Lindsay Purse. I'm the lead school psychologist for Williamsburg-James City County Schools.
And finally, Ellen Williams.
Hi, everybody. I'm Ellen Williams, the clinical director and the director of behavioral health services at the Center for Child and Family Services in Hampton and Williamsburg.
Very good. Thank you. And Lou, we're going to start with you. Would you like to lead us off with your remarks and observations?
I'd be glad to, Paulette, and thank you for putting this together and having it so well organized. And also, this will probably be said several times, but thanks to our grantee partners for all the work you do. We're really proud of you. As my fellow board members know, I'm a pitiful poor fill-in for Dr. Liz DeFalcon, who's at the college and is also one of the foundation's board members. But I do have some dusty cred, and that's credibility, Jack. I do have some dusty cred. I was Secretary of Health and Human Resources when the DeJarnette Center for Human Development in Stanton was renamed and expanded. I, in fact, picked the new name, the Commonwealth Center for Children and Adolescents. The then commissioner, who David Coe will remember, came to me with two names recommended by the staff, and I picked Commonwealth Center for Children and Adolescents, because we had plans at the time to make it a true statewide center. The state would develop satellites for professional training and education of the public, and would all be managed out of the center in Stanton. Sadly, that has not happened. However, the Commonwealth Center has 48 beds and admits the most complex patients, most frequently those with a temporary detention order. A temporary detention order is when a magistrate determines that an individual can be a harm to self or others. A local community services board, of which there are 40 in the state, including our old Colonial Behavioral Health, must pre-screen and show that there is no appropriate alternative placement, including private inpatient treatment, of which there's still a shortage in the Commonwealth. Well, who pays for all this? There are really two systems, the public system and the private system, which includes the uninsured. The public system is through the CSBs, which are the official state mandated doorway for behavioral and developmental services, unless you have private coverage and can go directly to a private physician, outpatient or inpatient facility. Other than direct state support to the CSPs, Medicaid is the largest payer for children and adolescent behavioral health. Medicaid covers at least 143,000 children and adolescents with behavioral health diagnoses, importantly, including foster children. All but about 30,000 of these are in Medicaid managed care plans. Others are in what is called waivered. These are waivered programs where the normal provisions, federal provisions of the Medicaid program are waived, and the state can set up special programs to help provide the care. And those tend to be fee for service. These plans pay physicians, those managed care plans, pay physicians in psychiatry or neurology, clinical social workers, licensed professional counselors, clinical psychologists, and the plans arrange and pay for mandated services. Those enrolled in the plans must go to the network providers that are available in that plan. There are 6 plans to choose from: Aetna Better Health, Anthem Health Keepers Plus, Magellan Complete Care, soon to be Molina Complete Care, Optima Health, which is a wholly owned subsidiary of Centera, United Healthcare Community Plan. United is the largest health insurer in the country, and Virginia Premier, which used to be wholly owned by VCU, but Centera has recently bought a major stake in Virginia Premier and will fold those recipients into Optima eventually. Now, here's the important thing. The plans are paid monthly to provide covered services and are at risk for those services. So what I mean is the plans get paid, and if the patients don't use any care at all, the plans get to keep all the money. If the patients use a lot of care and expensive care, the plans must come up with the money. So the state has put the plans at risk, but you can see the incentives that are there for skimping, although the plans are also face the chances that recipients would switch plans, and they do try, and they are monitored by the state quite carefully, actually. But it is a point of contention, especially in behavioral health, about how the plans pay for behavioral health and how often and what rules they have. And so just in April 2021, Virginia Medicaid established a panel to improve the way the plans process service authorizations, how they interpret medical necessity criteria, and claims processing for behavioral health. I have some facts and figures, Paulette, but I think I'll stop there and let the rest of the panel go on. You're on mute.
Mute. Thank you, Lou. That's a great background and context for the public structures that are in place to address children's behavioral health needs for those who are actually referred for services and have some public health coverage. One of the topics we'll be talking about shortly as well, too, is of course the workforce shortage, which is really affecting access to these services. So let us turn our attention now to some of our local providers and hear their perspectives. And we are going to lead off with Liz Urphy-Howard. So Liz, if you would just say a couple of words about the services offered at the Greater Williamsburg Child Assessment Center. And then I've got a couple of questions for you.
All right. Just very quickly, a brief history on the Greater Williamsburg Child Assessment Center. We began with a planning grant that was awarded to us back in 2008, 2009. Services actually began in 2010 in the form of assessment services. We did mental health and substance use disorder screening and treatment recommendations. court-ordered evaluations to include parental capacity, independent assessment and clinical coordination team assessments for residential placements. We call those IACs. Crisis services, we provide short-term crisis counseling, intensive in-home services, and community crisis stabilization. These services are mobile. And then we do care coordination and referrals, meaning we link individuals and families to community providers and family education. GWAC, the Greater Williamsburg Child Assessment Center, works closely with several community partners to include the Departments of Social Services in our catchment area, elementary schools, middle and high schools, and the Department of Juvenile Justice. Referrals come from these agencies, and we also refer to them. Referrals also come to us from local pediatricians and CHKD, and we'll often refer to them when there's a need for medical assessment and care. So that's briefly what GWAC does.
Liz, what behavioral health disorders were being noted at the Greater Williamsburg Child Assessment Center in recent years prior to the pandemic?
Prior to the pandemic, we were already seeing quite a bit of depression and anxiety, as well as behavioral issues that manifested in the school. Some of those behavioral issues had legal involvement, some did not have legal involvement. During the pandemic, we actually saw an increase in suicidal ideation, anxiety, depression, lack of motivation, and decreased academic performance. We suspect that this was due to isolation and loneliness. We did see fewer behavioral concerns since the children and adolescents were in remote learning and not actually in the schools.
So what are you seeing now with the increase of in-person services that are being offered along with the telehealth?
So interestingly, the majority of folks are still preferring telehealth versus in-person face-to-face. We have been providing in-person face-to-face counseling services, outpatient counseling services, and assessments since June of last year. But the families tend to prefer telehealth. It's a good option to avoid any scheduling conflicts and absence from school. The families are seen quite quickly via telehealth with less disruption to a work or a school schedule. The schedules have remained busy. We actually had 10 intake assessments last week, in addition to an IACT assessment and other assessments that were done at the Greater Williamsburg Child Assessment. We have continued to be very busy. We anticipate that will continue even through this summer. Typically over the summers, we'll see a lull in the need for assessments, but we did not see that at all last year, and we are anticipating that we will not see a dip this summer either. You're muted, Paulette.
I'm terrible for that. We will, I'm sure we'll be back for with some questions for you later. Liz, thank you so much.
Thank you.
Rebecca Sheffield, say a couple of words about the Flanagan Center for Counselor Education and the work that you do.
Absolutely. So we've been around for a while, even though the Flanagan name is fairly new. Counseling existed on campus at the School of Education of William and Mary for about 30 years. So it started out as strictly family counseling, and then a clinic for addictions and substance use began as well. Now, those clinics are combined under the umbrella of Flanagan Counselor Education Clinic, which means we're able to offer not only counseling services to families, but also to adolescents and young adults in the community who may be struggling with substance abuse. So we are expanding those services a little bit, offering also group counseling as well. And we offer all of those services free to all members of our catchment area.
Paulette.
I'll just stay off mute.
Good idea. Paulette, we had a question come in. I just wanted to pose.
Yes.
So one of our board members asked if telehealth assessments are as effective as in person. Would someone like to respond to that question?
I'll just say for Colonial Behavioral Health that our assessor at the GWAC is extremely skilled, and she's able to do very good assessments. However, when someone requests a face-to-face, we provide the face-to-face assessment. And if she discovers in the process of providing an assessment that the individual really does need to be seen face-to-face in order to get more adequate information, we will reschedule them for a face-to-face assessment.
So thank you, Liz. This next question, it probably applies to perhaps the whole group, but are you experiencing that all patients have an option? Are you experiencing that all patients have equivalent sufficient access to internet and related equipment?
I can speak to that one, at least from my experience. That's something that we were concerned about making the transition to telehealth, if all of the people that were seeking services were going to be able to access services by having the correct equipment. I think there's been one situation where a person had only a phone, but otherwise everybody in the community that has sought services from us recently, they do have the equipment that's available. One of the things I know is because we do serve a lot of children and families. I had been speaking to New Horizons Regional Education Center, and there are, for those schools that have laptops available, they're able to use those for counseling, which is incredibly helpful. So a smartphone, typically most people have smartphones, at least as far as we've seen so far.
Ellen, you put a comment in the chat box. Could you verbalize that a little bit for the group?
Yeah, I think I agree with Becca that we really have had very few that didn't have any capacity to do it. But we found quickly the challenge of, are you in a private area? Our parents, if we're trying to talk to the child and they want privacy, parents may be walking in. Some people have been in rather compromising situations when they've hooked on, like one person hooked on when they were in the bathtub. So we have to try to we learned quickly that we had to clarify that, and some people just are not going to have the availability for that, but most did, and I agree. We thought at first it's going to be a no go, and we found out quickly that most people have the capacity, at least with their phone.
Very good. I'm going to add one comment to Andy Bradshaw's question about assessments, the effectiveness of assessments by telehealth. And it's my understanding that, as Liz said, that they can often be done very effectively. And the exceptions to that are for very young children and for people with psychotic disorders. So in those instances, my understanding is that, the agencies will, try to, if at all possible, to do in person. Liz, can you confirm that? Is that?
Yes, that's absolutely true. We found out very quickly that some of the younger children just did not do well with telehealth. The attention span is not there. And we don't have many individuals who suffer with psychotic disorder at the ages that we see right now. However, we may have one or two that are that, and they would absolutely not be appropriate for telehealth. So we make every effort to bring those folks in and see them face to face. You're absolutely right, Paulette.
Mhm.
So another question that's come in from Beth Davis on our board is, how do current requests for consults and assessments now compare to pre-pandemic times? Ellen, you said that you think that they've almost doubled.
Yeah, oops, without specific numbers, but knowing that I'm finding my front desk up, sucking your thumb in the corner from all the referrals, that, yeah, there's just a lot of requests for counseling. And you find that seems to be across the board, because people will call and they say, I've called, 10 therapists and everyone is either has a waiting list or they're not even taking appointments. So it has become, I think, because of the situation. I also think that expansion of Medicaid has helped because now people can get help. But yeah, it's really becoming an issue in our community.
So I see other heads shaking. Others of you on the panel, same?
I agree. Referrals have increased. So yeah, we're also incredibly busy. We're trying to, figure out how we might take a break and recover from what we've been through over the past year. But we need to be there for folks who are needing counseling right now, and there are a lot of them.
Thank you.
Maybe we can defer the demographics question until the end when we have our discussion period. I think that's a pretty broad one. Sherry, thank you for posing that. And everybody, of course, does keep good data on the children and families that they're serving, but I think we will come back around to that. Becky, let me come back to you. What are some of the most common presenting issues for families over the years, and how have those changed within the past year plus?
What's really interesting is when I heard Liz talking, her list, it sounds very much like the list that I have. So over the past few years, we have seen families who are referred to us for various reasons, but among those, definitely problematic communication, family transitions that they may be having, behavior in schools, academic decline for children, and also lack of motivation, and suicidal ideation. So those are among the top presenting issues that we have been seeing as over the past year. It's really interesting how those things have shifted. We're still seeing some of the same things, but it's what we're hearing is that some additional problems are being illuminated due to the change. Due to the way that people are spending time differently. And, we do hear the word, as you mentioned earlier, isolation. That's probably the most prominent word I think I've heard, isolation, but yet I'm also hearing that isolation has created different circumstances for having families really examine and think about and maybe even illuminate some of the problems that they were not aware of. And those would include definitely issues with communicating with each other. And so I don't want to say there's, I hate to say there's a silver lining, but in some ways, I think, some of those issues are coming to the forefront so that we're able to address them now.
Thank you, Becky. Thank you to everybody too. Thank you to our board members for participating with your questions. We've got a question regarding, are there unique populations that are proven to be less inclined to access telehealth? And I think, we've sort of, encountered the technology issue and talked about, populations that might be, it might be less appropriate for assessments, but do any of you have comments on this question? Unique populations less inclined for telehealth?
I would say, which isn't necessarily appropriate for this panel, but older family people that are not technology savvy will not, I think they are more or less likely to be wanting to connect with telehealth. They don't know how to do it. But I don't know if, I think a lot of the youth that we're talking about now, I mean, that's just a real common thing for them, is to hook up and talk. So talk online. So it's not unusual. I don't find that the youth or families with youth are hesitant to use it.
I totally agree with that. We actually had some youth who had to teach their parents, how to how to link to a Teams meeting or a Zoom meeting, and that actually empowered some of them.
I would agree with that. We actually use that as a particular technique of family counseling, is using that opportunity for a role-taking experience for kids, because they're able to lead their parents, and just being able to create the communication around that has been pretty interesting. I also want to mention just one anecdotal example of a family that we've seen with 7 children, and it worked. I mean, they had one phone, and I was thinking, how on earth are we going to make this work? But there was one phone, and they were able to capture everybody within the screen, and it worked. So I was really blown away by that.
That's great. Becky, let me ask you also, what are some of the promising practices and innovations that you think will be constructive and sustainable going forward?
So one of the things that I didn't mention was, there's also, with the illumination of communication issues, there's also the illumination of experienced trauma that we're hearing. One of the interesting manifestations of doing telehealth is, it seems, at least for us, that families are kind of giving us deeper information or more personal information quicker. And I wonder if that's maybe because they're in the comfort of their own homes. So they're kind of on their turf. They're not walking into the doors of this maybe big building that might be a little intimidating. So they're sharing a bit more information, which means we're getting to the heart of things and really learning a lot about trauma that kids, adolescents, parents, grandparents have experienced, and how that might be impacting the system. So some of the things that we've done, one of them was to create an in-depth training of really addressing issues of trauma, and we brought in experts. We actually have one of the most foremost experts on trauma on faculty right now, who helped, and we put together a panel of faculty and doctoral students who created this wonderful trauma-informed counseling training to add to our curriculum. So it was a little bit more in depth and very specific to our population. A couple of other things we've done, we're trying to partner as much as we can with others on campus. So we've recently partnered with the immigration clinic on campus, and they often see asylum seekers who've experienced tremendous trauma as well. And so we're able now to partner with them and to be able to see the families that are using the services of the immigration clinic.
Wow.
Yeah, and I don't know that I had shared with you that, because that is something that's fairly new. So we started a pilot program, but we now have a few students who are bilingual, which is really helpful because we're able to offer services. There's always been a need, and we've been really trying to recruit diverse students so that we can meet those needs, particularly bilingual students. And now, we have that ability. So that's one of the things we've done. There are a couple other things we've done. Another thing we've done is actually we partnered with the Governor's School to be able to offer diversity, equity, and inclusion training to their staff, to their parents, and to their students. And the main purpose of that is to be able to support marginalized students by helping with language and discussing things like race, discussing things like politics, and some of the interesting things that are coming up. We're seeing it on the news, we're having conversations around it, but really showing adults how to talk to kids and adolescents about those very difficult topics.
Wow. Thank you. That's, some silver linings there. And some reasons for hope. So interesting about people doing telehealth and being willing to share on an even more personal level and really being able to get down to some of the issues around trauma. Thank you. Let's move along, and I am going to call on Lindsay Purse. Lindsay, just tell us a little bit about your job description. We know you have 11,500 potential clients in the James City County school system. But just tell us a little bit about your position.
Well, the school psychologists, we are typically involved, and we kind of have two sides of our job. We're involved in mental health intervention, but we're also involved in special education evaluations and identification. We do spend a lot of time on that piece and do a lot more consult with the mental health piece and meet with parents and teachers about concerns about their students' mental health and behavioral health.
Wow. Well, we certainly, like everybody who's with us today, all the professionals, we really appreciate what you do. Tell us about some of the longer term trends that you can identify from your vantage point and how these are being addressed.
I will echo what others.
Lindsay, your audio is breaking up. It may be that your connection is unstable at the moment. Perhaps if you turn off your video for a moment and just respond with your audio, we might be able to hear your transmission. Uh-oh. I think we lost her altogether. Okay.
Okay, well, let's just make a little edit here.
All right. I am having.
There you are.
Sorry, I'm having internet issues too. Yeah, I don't know if you can hear me.
We can now.
Try turning my
I'm sorry, Lindsay, it's still
video off. See if that helps.
Oh, here we go.
Okay. You can hear me now. Okay, good. The schools have really focused on kind of creating behavior schools. And can you hear me? Okay.
Yes. Oops. Lost her again.
How about if we call on Ellen and then come back to Lindsay?
Sure.
Let's do that. Ellen?
Yes.
Tell us just a little bit about what you have done around child and adolescent behavioral health. And then I've got a couple of questions for you.
Okay. And are you asking, Paulette, in particular, just what our agency offers?
Yes, just a little bit about
Yes,
your
okay.
services. Yeah.
Sure. Specifically in Williamsburg, obviously, one of our specialties, which we have really invested a lot of energy into, is training our staff to be trauma informed and to provide evidence-based trauma services. So our mental health services are there for all ages and also offered in Spanish, which is the good news. And so we've been doing that. And I agree with you, Rebecca, we're getting so many who are coming in after having horrendous trauma. We also offer neurofeedback for youth. which got a little bit put on hold with the pandemic, but it's back and functioning. Neurofeedback is a way to address particularly attention deficit areas, issues, behavioral issues. We hook them all up with little electrodes on their head, and they learn to control their alpha, beta, theta waves by watching videos, and that helps them to learn to calm down. It basically rewires their brain. It's extremely effective. So those are our main programs that address and are there for children.
So
Very good.
we've had another question come in the chat box. Sherry's asking, how does or does not William and Mary's Office of Community Engagement work with the School of Education and Family Counseling? What is their role in behavioral health, if there's any at all? Rebecca, could you possibly respond to that?
Yes, so community engagement, we do work with the Community Values and Restorative Education office, but so far we haven't done much with community engagement. As far as family counseling is concerned.
So because community engagement tends to be more volunteer engagement, is that correct? As opposed to the work that you're doing in counseling?
I would think so. Yeah, we haven't had much interaction so far in regard to behavioral health.
Okay.
Okay. And Ellen, tell us a little bit about how we talked in preparation for this. You were telling me that the pandemic has actually improved your services for the uninsured and challenged members of the community. So I would
really
found
it has.
Love to hear a little bit more about that.
Yeah, I think we've taken lemons and turned them into lemonade, and it was really exciting. I think as all of us, we just went into a panic mode. But we deal with the poor, and so when you think about how many families can't make an appointment because they may have to ride a bus here or their car breaks down, and what has been exciting is to get a call from a parent to say, we can't make it, our car broke down, or one of our children is sick, and we can say, oh, hold on, let me send you a link, and we'll do telehealth instead. So for transportation or childcare, so many parents they're dealing with, we don't have one who has 7 children who are trying to do a video chat, but we have, they have children. One might be sick, or they're trying to come in, and it's difficult to provide therapy because they may want to bring the children into the session with their brothers and sisters, and it's kind of chaotic. So now we can be able to eliminate the childcare issue for the poor, which is expensive for them. And when you think about it, we would love to be able to offer, we are open 4 nights a week. We would love to be able to offer everybody appointments after they get off from work, but that just can't happen. And so now oftentimes people can call in during lunchtime. They go into their car, or they get their children because they're being homeschooled, and now they don't have to take time off from work, which saves these folks money. And our adolescents in particular, because that was one of my specialties, is adolescents. They're home alone, their parents are working, and so now we have this opportunity to see them when somebody would have never had time to even bring them over. So there's a lot of kids who got disconnected from therapy because parents just didn't have time. So now you can. And in reality, we don't provide in-home therapy. So now it was really interesting to see an adolescent, and they take you around and they show you their bedroom and they show you what they're doing. And, it really made it real, and you felt more connected. So I think it's just been this awesome opportunity. And plus we've expanded to areas where they're isolated. For us, sometimes it could be out in Gloucester, they could be way out in James City County, they can't easily get there. Now we can reach people actually all around the state if they needed therapy. So I think we really, for many of us, but our agency in particular, they've taken lemons, and we have gotten really sweet lemonade from this.
Very good.
Yeah, I was just going to add to that. That sounds very similar to what's happening for us. One of the really interesting and unique things that's happening as well is because we are doing telehealth. If we have family members in different places, they're able to join and have family sessions together, which is not something we were able to do before. So perhaps there are parents or guardians who may be co-parenting but living in different households. All the family members are able to participate because we're now connected by technology.
That's great.
Another question, actually, Rebecca, stay on because this one's towards you. So Carla Javier with CDR was asking that you mentioned a trauma expert at William and Mary and wondered if you could share who that person is and what their role is.
Yes, absolutely. So Dr. Craig Cashwell has recently joined our faculty. So he is a member of our counselor education and supervision faculty. And he has written several books, lots about spirituality in counseling, but also trauma in counseling, dealing with trauma and working with trauma-informed in trauma-informed ways.
Great.
Good. It's great to know we have that expertise in the community. Ellen, the other thing I wanted to ask you, and you've already mentioned trauma, but how has this approach, do you think, for mental health services, maybe on a little bit of a broader scale, how has it helped to address the overall mental health of the community and individuals and in public health in the community?
Well, Paula, as you know, this has kind of been my passion for quite a few years because in 1997, they did a lot of research on the adverse childhood effects. And when we think about it, that was in 1997. But I would really say over the last particularly 5 to 8 years, we've all sort of embraced the idea that when people experience traumatic events, it not only changes them emotionally, but it changes them physically. And so I think the exciting part about that is the awareness of it. For example, even with our juveniles now, more and more courts now are saying, we're getting youth sent to us and said, we want you to do a trauma assessment on them before we sentence them, because they're starting to realize, why would we just put them in a detention center when we haven't addressed the trauma that's going on? So what we've learned too, research shows only about anybody who experiences a traumatic event, only 40% actually develop PTSD. And part of that is because we can add our awareness in the community, I think, and our awareness of resiliency factors and addressing a trauma early on can avoid all of the long-term effects of suicidality and depression and insomnia, the academic difficulties, let alone at which the adverse childhood effects showed the long-term health effects. So and with this knowledge, I think we're becoming more aware. 40 years ago, I was one of those nice Freudian, it's always mom's fault kind of therapist. And I've learned that how to be a trauma therapist. And so I think our awareness in our community is saying, let us send these children to someone who is going to use evidence-based trauma therapy, which oftentimes can be effective in 8 to 12 sessions, as opposed to just your general talk therapy. So therefore, we're helping people sooner, giving them those resiliency factors, and also if they are needing help, that we're getting them help in a faster method. It doesn't need, they don't need to be necessarily in therapy for 2 to 3 years. We can help them faster. And that's very, very exciting as far as preventing some of these issues in our community.
That is very exciting because
I'm sorry.
When we think about mental illness, we sometimes don't progress to the point of thinking about treatment and healing and building resilience and preventing, negative cycles. So, yeah. Carol?
I'm so sorry to interrupt. I just wanted to say that it looks like Lindsay has joined us again by phone. And so perhaps we can try once again to engage Lindsay in the conversation.
Very good. Lindsay, I wanted to ask you, what are some of the longer term trends you can identify, and how are these being addressed?
I'm hoping that I'm not breaking up now. I'm going to leave my video off since I'm on my
Okay.
phone, since my Wi-Fi has gone down.
Oh,
Yeah, super good timing. Basically the schools have really been working on, it's VTSS, which is our tiered systems of support, which is this, one of the basic tenets of that is just this idea that we're going to create consistent behavioral expectations across the school division, and all be on the same page, so that we're reacting and having the same information in terms of when students are having social emotional issues. And then the other piece to that is adding social emotional learning into all classrooms as part of the curriculum. We've been really focused in elementary in particular in the last couple of years. This year, we were pushing out some new curriculum. I will say that has been a little bit more difficult to introduce new to teachers this year, especially when trying to figure out everything new. But we will continue to kind of work on teaching all of our students some of those social emotional skills, hoping that we're increasing coping skills, and then hopefully they are not needing referrals as much as they are right now. We're working on self-regulation skills as well. And then for staff, we've been doing a lot of the trauma sensitive training, trauma informed care training, so that our teachers understand the trauma backgrounds that so many of our students are coming from.
very good.
And I also just wanted to bring to people's attention in the chat room, Rebecca Vinroot has put a link to the Greater Williamsburg Trauma Informed Community Network for more information. So if anyone would like more information about the Trauma Informed Network that is now here in Williamsburg, there is a link in the chat that you can get to.
Thank you. Thanks, Rebecca. And Lindsay, what are some of the challenges with supporting students who may be experiencing some of the more acute mental health needs? And how has this been impacted by virtual learning?
Well, virtual learning has been quite the challenge, I think for everyone. And we've certainly seen, from the mental health side, we've had difficulty trying to figure out how to navigate that with families, just as I think everyone else on the panel has. Our school counselors have wonderful relationships with parents and their students. And so they've been able to meet with their students virtually. And the school psychologists and school social workers, we've been meeting virtually with parents in meetings all year, since we closed last March. And we really have spent a lot of time listening to all the stress that families are going through and assuring them that they're not alone, because we've all been struggling. That isolation word has come up quite a bit in our meetings as well. And I think because of the more extended virtual learning that we have with our secondary students, they definitely felt the isolation. I think also developmentally where they are in terms of needing their to see their peers more. They definitely felt the isolation piece. We are making lots of referrals, so thank you to everyone on the panel for fielding all of the referrals that we're making. And we've been hearing the same things in terms of, families call us after they've called 10 people and they were like, do you have any more leads? And we're, just encouraging them to get on wait lists at this point. We know we have really great therapists at the Greater Williamsburg Assessment Center and Child Family Services, and even at William & Mary, we're referring lots of folks there, and any of the private practice folks that we can. And in some ways, the pandemic has been good in helping some families that we were trying to convince them that getting mental health services would be a good thing. I think being at home and having some of those issues highlighted a little bit more convinced them that it was time to go seek services. Unfortunately, there's a lot of folks seeking services right now. So they have had some difficulty getting access.
Yes, one of the things that's really coming out listening to the panel is how much all of you are a team working together, and we so appreciate that. Lindsay, any other comments? I know one of the things you mentioned when we were preparing was children that are on the autism spectrum disorder, on the spectrum.
Yeah, so we talked a little bit about assessments. When we're doing our assessments for special education eligibility, we have really struggled with some of those pieces. We have not been able to do cognitive or educational assessments except for in person. So we started doing that back in August. And assessing for autism has become really challenging right now. A lot of what we do in those assessments is watch facial cues, social cues, facial expressions. We want to see if kids are picking up on ours and see how they're using theirs. And we have mask mandates like a lot of places have had, and that makes it really difficult to see facial expression. So that has been quite a challenge since COVID.
Great. Okay, I just want to open it up. I don't know if there are foundation board members or others who have questions that you might like to pose to either the panel, the entire panel, or to individual panelists, but we are all ears, and we're very happy to address whatever you might want to ask.
So everyone, please feel free to turn your videos back on so we can see your faces. And if you have questions, feel free to unmute and direct your question to who you would like to perhaps answer it, or the group as a whole. And Marcia Obremski made a comment in the chat room about how the pandemic has created increased awareness around trauma and stress. And it seems to be overall bringing people together more as a community, because they are talking more openly about the challenges that they're facing and adjusting to both working remotely and then trying to transition back to work and helping their kids with school. So it's a great comment in the chat board if you wanted to see that. Questions?
Thank you, Marcia. Well,
We've left you all speechless. That seems impossible.
we covered a lot in an hour. I'm surprised as we have gone along. Are there any other promising practices or any other challenges that you feel did not come out for the panel? Are there any other items that you would like to bring to the attention of the group today?
Paulette, I have something you and I have emailed about, and I wondered what the clinicians think about this. Is there's a relatively new mental health access program that the
Right.
state is running, and my understanding is, correct me if I'm wrong, but my understanding is they are trying to bring pediatricians and family medicine folks up to speed with some of their behavioral health clinical skills in order to expand the availability of services. And I understand that they've been doing some training in Williamsburg, and I wondered if anyone has run across them or knows about this statewide program.
This is, like Lou said, this is a relatively new program. Virginia received funding from the Health Services and Resources Administration, I believe starting in 2019. It is vmap.org, Virginia Mental Health Access Program. And just to put this in some context, one of the things that we've seen today as we've gone through the discussion is the demand for services and shortage of services. And the people in Virginia who have training in behavioral health for pediatrics is not up to what the needs are across either our community or other communities in the state. So VMAP, one of their central objectives is to train primary care providers like pediatricians on behavioral health, because these are the clinicians who end up managing children that have behavioral health disorders, and to increase their skill level and their confidence. And this is happening by doing the training of the primary care clinicians and also consults. And like Lou was saying, and they're about to get into doing what they're calling care navigation as well. So this is an exciting new program that is, that will be benefiting our area and benefiting the state.
And Paulette, if you go to the website, you can see that they've divided the state into regions, with the Tidewater region, the Tidewater region. And there's a whole team of CHKD, psychiatrists, psychologists, and others who are part of this effort, and I think are a resource for anyone.
Yes.
And Terry Lane from Community Health Solutions has put a link to the VMAP website in the chat room if anyone is interested in that. Also, I wondered if we could go back to Sherry's earlier question about what are the demographics of children being served in the different agencies. So I wondered if we could just quickly move through our panel, and if you could tell the group a little bit about the demographics of the types of children that you serve in your agencies. Ellen, should we start with you?
I was just thinking, oh, Carol, don't call on me. No.
Sorry.
And I couldn't look down like I was in the classroom. I couldn't look down, but okay. Not having the numbers right in front of me, but I like numbers. Okay, I would say that the highest majority of our clientele for youth would be from the elementary school age. I would probably say that of youth, that would probably be about 60%. And then 40% would fall into the adolescent age range. Racially, in Williamsburg, we actually primarily, the higher number, but it's close to even, but is Caucasian versus African American. In Hampton, it would be the reverse. And we have about 4% served that are Hispanic ethnicity.
Thank you.
Whew.
I would say,
Yes.
this is Bonnie Griffiths, lead school social worker. I would say one of the ongoing challenges continues to be when we identify a student as requiring special education services under the category of emotional disability or autism, is linking them then with mental health, behavioral health services. Sometimes the reason, a lot of times, especially at the elementary level, well, and even going up from that, the reason that they qualify under that category is there is a trauma history within the family. And so often these are not the families who really want to link to services. They want to keep their lifestyle to themselves and don't want really someone poking their nose in. However, these children can be year after year after year, continue to have extreme behaviors. We, in a self-contained classroom, it's not uncommon to have to call the police on a regular basis. And even some of our children that require self-contained autism also can have some pretty extreme behaviors and may end up before the FAP team or for all kinds of services that can be quite expensive. So I would say just in general, it's an ongoing challenge to try to somehow help the parents understand. And then once we try to link them with services, if there's a lack of availability, those are going to be the parents who just back off real quick. That if I don't get multiple phone calls, then I'm just going to forget about it, and they slip through the cracks.
Thank you. Liz, could you speak to some of the demographics at the Child Assessment Center? You're on mute.
Okay. I've got some data in front of me. We serve the ages of 6 to 18. Occasionally we'll have a few that if they remain in school at the age of 19 or very rarely 20, we will continue to see those individuals. The majority of folks that we've seen come through GWAC are Caucasian. Second is African American. And then we've got some Asians and Alaskan Native, one. We have more females coming than males, but not by much. And let me see. The majority of the highest percentage in terms of age is 14, and that's followed by the 16 and 17-year-olds. So at the last time we did a data collection, it was 14-year-olds coming in first, followed by 15 and 16-year-olds. So more females than males, although not by much. And then the highest in terms of race is Caucasian, followed by African Americans.
Thank you, Liz. And Becky, what about at your center?
Absolutely. So I'm actually getting ready to run the demographics at the end of June for this fiscal year. But I do have some data on family configurations that I think would be very helpful. As far as age and ethnic or racial background of children, that it's very consistent with what has been spoken already. But as for family configuration, we have single mothers are the most prominent or the most the largest group that we have that are referred, with 43% being single mother headed families. Single father headed families make up about 2%. Families with both parents, 29%, and blended families, 21%. And that includes step parents, stepchildren, and there are about 5% multi-generational families. And as far as trends go, I can speak to this. I'm really looking forward to finding out what the actual data show. But some of the trends are that we're seeing more men in counseling. And I wonder if that's because of telehealth and maybe availability, but also maybe willingness. I kind of suspect maybe lack of stigma. There's less stigma being, in your own home than walking into a counseling center. So we're seeing a lot more dads, stepdads, male guardians. In addition to that, I would say that our most, if we had to name, a profile of a particular identified patient in our families, it would be a 9-year-old boy. However, that is shifting and we're getting many more referrals for adolescent identified patients in our family systems.
Thank you, Becky. Bonnie, if I could loop back to you for just a moment. Are you still with us? I wondered if you could define the FAPT team for the group, or if there's someone else who could do that. Bonnie had to step away for a minute.
So,
no? Okay.
Marcia could speak to that as well.
Yeah, the FAB team is basically a multidisciplinary team that is made up of the CSA, the Children's Services Act, coordinators from social services. You would have the court services unit. You would have some of our staff, providers. We have family representatives, private practitioners, and they review cases to determine what services would be recommended by that team for funding through CSA. Did I capture it, Rebecca?
Yes, you did a great job. Every locality in the state receives funding through the Children's Services Act to implement the program and to provide funding for services that Medicaid doesn't fund, and basically to lift any barriers so children in need can receive services.
Great, thank you. We are an industry of acronyms, that's for sure.
I was just going to ask if I could call on Rebecca to say a few more words about the Trauma Informed Community Network, which has been a wonderful innovation. The word of trauma has come up very frequently when we are talking about behavioral health care, and turning it to topics around resilience and healing. And Rebecca, just tell us a little bit about the local Trauma Informed Community Network.
Sure, thank you. And I will have to say, when we started out our network in 2019, I remember talking to Ellen about it because there are chickens, as we call them, all over Virginia. So we're fortunate to have one in the greater Williamsburg area. And we are focused on awareness and training and making sure that everybody in the community, not just providers, but community members, recognize the impact of trauma and how important it is to be aware and to just recognize the signs. I think certainly during the pandemic, we all know that was trauma inducing, but prior to that, and it will continue to have the repercussions of it. And so, for example, in the schools, you're seeing children have behaviors. Well, that could be a trauma trigger. I think we need to just be aware of that. And that's the purpose of the network, is just to make sure that all of our members are aware of it. We have certainly different facets. We focus on schools and health and the legal community. Public awareness and training is a big part of what we do. And we're hoping to have more trainings available. So, maybe pediatricians can get trained on it. We can do a whole host of things once we have the availability for that, because I remember having that light bulb go off, recognizing how much trauma can have an impact. And so it really is about, the what happened to you question that I think is becoming, fortunately, asked more and more by folks, and not why are you acting like this, but what happened to you? So I think the more we can just become aware of that, I really do think it will be transformative to a lot of the work we're doing. So yeah, so we have a strategic plan that we're implementing, and we meet every other month. And so just go on the website. We have a coordinator, Sherry Wiltshire, who's on the call, and we can get you connected. And we'd love to have everybody join our network so we can spread the word.
So we have one last question that just came in from Amy Lassev. Amy, would you like to ask your question?
Sure. I just wanted to raise the question to everyone, kind of based on your expertise and what you're currently seeing. What are you anticipating to be the biggest concerns come next fall when we see so many of our students return into the classrooms? And we know that some of that social isolation will go away, but perhaps there will be other emerging concerns as students who have been, isolated for over a year, now re-entry into schools and social settings.
I would say, just thinking through that, great question. Transitions are hard. So in the beginning, it was very difficult to transition to a new way of life. And we've been now in this new way of life and kind of making our way. And, there's almost developmental phases to this whole process. So I imagine that making the change back, it's another transition, which is going to, come with it lots of issues and possibly bumps in the road as we try to find that new normal, which is going to look different, I'm certain, than the way it looked before. So I am looking at that. I'm also thinking, the things that I'm seeing in families right now, the reflective process that's happening in a way that looks different. I think that's going to change, maybe priorities, maybe I think there could possibly be, more changes that come that we're not aware of. So I'm hoping to be prepared for that.
Thank you.
One thing that I would add with the kids that I've worked with is for my kids that had social anxiety or were bullied, they were like pigs in sloth. I mean, they were like, yes, I don't have to go to school, and they blossomed. So we're going to have to deal with them going back into the school system and all the anxiety that's going to create for them. And I also find right now, I'm finding a lot of them, just even as they start going back, I mean, a lot of us got used to working in our pajama bottoms, and we got to sleep a little bit later because we didn't have to commute. I mean, so some of these kids were having to get up at, 5:45 in the morning, and now they get to sleep till 7:30 and roll out of bed and eat breakfast while they do school. And just like the adults, a lot of them are struggling with, I don't want to go back there, and so I think it's going to be an interesting challenge for this school system to get them back and kind of get them all back motivated, that's going to become their new normal again. So.
Mhm.
I'll jump in too. I know I'm still keeping my video off just so I don't lose audio, but I think when we've had kids come back this year, we've sort of seen that mix of reactions. Like we've had kids who couldn't wait to get back in the door and see people, and they, practically ran into the building. And then we've seen others who have done really well in virtual learning, and the transition back is going to be more difficult. I do think there's a positive of that we are going to be offering a virtual option for a lot of students. And so I think some of those that have really flourished will, do have that option still. So I think that's great. But, I think September is going to be super interesting. I think we'll have some kids that start off doing great. And then as the excitement wears off and the stamina issues start showing up, we're going to have to really work hard on getting some of those kids used to doing a full school day again. And then there'll be others who, walking in the door is going to be really difficult and getting them started. But then once they're kind of back in the routine, I think things will get better. So I'm sure we'll still have lots of referrals for everybody. So get ready. There's going to continue to be phone calls coming your way.
Well, we didn't talk about substance use, but I also believe that we're going to see an increase in that area as well. And, I'm sure Kim at Bacon Street, she may already be seeing some of that.
Yes, I can say that very clearly. Yes, we are definitely seeing increases. I think that as a provider and as an agency in the community, there are, I can just echo what everybody else has been saying on this call. Everything that that all the other private providers and agencies have been discussing, I was like, yes, absolutely. That is exactly what we are seeing at Bacon Street. I'm concerned about substance use, especially. I think that we're going to continue to see that be an issue with many of our young people. We've seen increases in that already with clients, and I think we're going to continue to see that be a growing trend. So thank you, Marcia, for bringing that up. I really appreciate it.
Thank you, Kim. Paulette, do you have an invitation for our group here?
Very good. I've got just a couple of things. We've covered a lot of territory, and we are so grateful to our panel, to our board members that are attending, and grateful to everyone who has participated and made this so interactive with your comments and questions. It's been quite a lively discussion, and we really appreciate that. Again, the themes of collaboration, working together, as you can see from the various providers of services that are here in the group, the panelists and others, there is wonderful synergy going on. And that offers a lot of hope for us being able to have the broadest community impact that we possibly can in this critically important area for adolescent behavioral health. So thank you to all of you for what you are doing every day for the health of our community. Our hats are off to you. I have an invitation for you. Lou mentioned a few minutes ago the Virginia Mental Health Access Program. And I think all of you on the call are aware that we host meetings several times a year of what we call the Children's Behavioral Health Provider Network. So you will be getting an email invitation, but you can mark your calendar now On September 29th from 9:30 to 11:30 will be our next meeting of the provider network. And our special presenter is Allie Singer-Wright, who is the program director of the Virginia Mental Health Access Program. So we will be able to use that time to learn more, to be able to ask questions of her. I commend I think Terry posted the website. I commend the website to you. It has a lot of great data and also exciting announcements about the services that are coming online. So I'm happy to be able to look forward in that regard as well. And Carol, I'll just turn it back to you if you'd like to give us a send off.
Thank you, Paulette. I have to say this has been very, very interesting today. Great questions from those that are participating and listening. So thank you for feeling free to put your questions in the chat box and to discuss afterwards. And thank you to all of our panelists for pulling together your thoughts and ideas and remarks today. And I would be remiss if we didn't take this opportunity to congratulate Ellen Williams on her retirement. Ellen, you have been a huge service to this community for decades, and we can never be grateful enough for all that you've contributed to the care of this community. And we just wish you the best of the best in your retirement, and you are irreplaceable, but hopefully we will find someone who can try to begin to step into your shoes. But again, thank you for all that you have done for this community over the years.
Oh, thank you very much. And it's just been an honor to work with all of you. Really, I will leave with you all tender in my heart, and I know you'll do great things.
So thank you. Well, thank you, everybody. We appreciate your time this afternoon. We hope that this has been helpful. We are recording this session, and that will be made available. So if you are interested in watching this again, or you want to share it with others in your organizations or people in the community, feel free to do so. We will email a link to that recording out to you once we have it complete. So thank you again. Have a great week and take care. Bye-bye.
Thank
Thank
you.
you.